Welcome to the People's Health Briefing, a component of the Trusted Voices campaign. I'm Dr. Noha Balada from Roots Community Health Center, reporting for the week of September 26, 2022. Today, after a status update on COVID, MPX, and polio, I am going to talk about whether there is anything we can do locally to ourselves after we think we might have been exposed to COVID. And I'm going to specifically talk about nasal irrigation and oral hygiene. As health professionals rooted in Oakland, serving some of the people most vulnerable to getting and suffering from COVID-19, we're here to cut through the noise to give you information you can use to make choices that will keep you, your loved ones, and your community as safe as possible. The goal of the People's Health Briefing is to empower you with our best knowledge and thinking every Tuesday morning. As you can see here, total cases in Alameda County over the previous 14 days continue to come down, but really kind of slowly. We're at 2758 cases. Last week when I reported, we were at 2917. So really not going down quickly, but nonetheless, we're heading in the right direction. And so that is a good thing. Same thing with test positivity rate. We're now at 4.5%. Last week when I reported, we were at 5.4%. So good to see it coming down as well. And the best news, I think, is that here in Alameda County, we're finally starting to see what looks like a meaningful decline in the number of folks in the hospital with COVID-19. Last week when I reported, we were at 106 in the hospital, 16 of those in the ICU. So we're finally down to double digits out of those triple digits with 80 people in the hospital, 5 of those in the ICU. Of course, this is still devastating to have folks in the hospital and in the ICU, because we know that that means we have gotten into a pretty severe place with the COVID-19, but very glad to see it finally looking like it's no longer just doing the zigzagging. We're finally seeing some motion in the right direction here. However, nationwide, we are still losing over 400 people per day with SARS-CoV-2. This is really significant. This is, as many people have pointed out, a 9/11 worth of deaths every week. This is over 150,000 people per year. So really, this is far too high, and it has been kind of zigzagging there for quite some time. So we will be looking forward to seeing that hopefully come down soon. Now, in terms of variant proportions in the US, we're seeing the same trend where the BA.5 seems to be slowly getting displaced with some other Omicron variants. Namely the BA.4.6. It was about 10% last week. It's almost 12% this week. So it just kind of keeps marching along. And so the CDC is now showing these new variants, BA.2.75 and BF7, which is an olive green at 2.3%. And so we're tracking those now. We sort of do not like about BA.4.6, as well as it looks like the BF7, is that they seem to potentially be getting around one of the monoclonal antibodies that we use, which is to protect people for 6 months who may not have received the vaccine or did not mount a good response to the vaccine. And so we're going to be keeping an eye on that. Also, the BA.2.75 does have some concerning mutations on it. It first was identified in India back in May, and we've been tracking it since, and just now kind of starting to see it increase here in the United States. So we're going to have to keep an eye on it, because none of these mutations are looking great. They look like they help the virus evade some of our prior immunity, some of our prior antibodies. And of course, we know that as long as we have as much transmission as we still have, then that's just more opportunities for even more new variants to come on the scene. With respect to polio, I've updated on polio more extensively in the last couple of briefings. I think that the only update I want to provide is that the CDC did announce that it was going to be doing wastewater testing in geographic areas with low vaccination rates. And they will be testing in the wastewater, similar to how we've been testing for SARS-CoV-2 in the wastewater. And so I'm glad to hear that there's going to be some kind of surveillance of polio, but I have to say that this seems like something we should be doing everywhere. I've been inquiring here locally about when we can expect to see some kind of testing in our wastewater, because we have the infrastructure. And so this is a perfect example of how we could be better off in preventing the next crisis because of new infrastructure that we have in place from the current ongoing crisis of SARS-CoV-2. And so I think it would just make a lot of sense if we were testing everywhere, because although it's true that if we're in a location with low vaccination rates, we have more people to worry about, but it doesn't change the fact that if there's polio circulating in our area, it will be a good thing to know about. But remember, the remedy for this situation with polio suddenly now being here on the scene in the United States after really, we thought we had kind of left that in the rearview mirror. Solution is pretty simple. Get vaccinated. So if you or your children are not vaccinated for polio, why? Just why? We don't want paralysis. We don't want paralysis. We don't want vaccine preventable paralysis. So that is just something that we would be very foolish to allow to happen again. And so let's please go ahead and make sure we're vaccinated. If you're not sure, if you are in a higher risk situation, like you travel to other areas that may have more of it circulating, or now the CDC is even recommending boosters for adults who are healthcare providers. The challenge is we don't really have a good test that's going to test against all the types of polio. And so if in doubt, it's not going to hurt to get a booster. So I know that's not the greatest advice, but most of us are covered from our childhood vaccination series, and the protection does seem to be pretty durable. So really who we're worried about here are completely unvaccinated children and adults, because you will be susceptible to paralysis now that we've got some polio circulating in our environment. So bottom line, get vaccinated, please. And now on to MPX, or monkeypox. So we're continuing to see a creeping up of cases worldwide. We were at about 62,400 last week. We're now at almost 66,000 cases worldwide. In the United States, we've also gone up by a couple thousand, from about 23,800 to 25,162 cases in the US. In California, a little bit less of an increase. We're now at 4,886 cases from about 4,600 last week. And in Alameda County, from 209 to 216 cases. We know that there's a lot of delays in getting tested and in getting the results. And so we know that these numbers are likely really undercounting quite a bit. We are hearing still of a lot of people being diagnosed with some other rash and then sent home to potentially spread this to others, but also to get in a worse situation in terms of worsening painful rash and so on. Also, we're just still really learning about this new MPX outbreak that we're having here, which is, again, very different from what we've seen previously in endemic areas where we have sustained human-to-human transmission and really an ongoing outbreak. And so we're just going to keep on learning what we can about this. The one thing I wanted to mention is that the CDC, in its Morbidity and Mortality Weekly Report from September 13th, reported 2 cases of MPX that led to encephalitis. And so this is pretty concerning because this is actually an inflammation of the brain and the surrounding tissues, encephalomyelitis, that happened in two previously healthy, from all that we know, immunocompetent men, so in their 30s. So young, healthy men without a compromised immune system, two of them, one in Washington, D.C. and one in Colorado. And they got very sick, as you would imagine, from inflammation of the brain. And so they had to be hospitalized and treated. After like a month or more in the hospital, they were able to be discharged to rehabilitation, and they were again able to walk with assistive devices. So this is serious business, and the fact that it happened in people who did not have underlying conditions and people who were in their 30s, of course, should give us pause, because we know that, there's nothing about this virus that would keep it from spreading into more vulnerable people. We've already had cases of MPX in children, including in an infant. And so this is just, we get more concerned with our small children as well as pregnant moms. And so we're just going to have to do what we can to get absolutely ahead of this, so that we don't see more complications like this. But until then, we'll just keep on learning all that we can. And so now I wanted to turn to a question I've been getting from folks who want to know, is there anything that they can do after they've been exposed to SARS-CoV-2, or maybe they've been a little higher risk environment, and now they're wondering, is there anything that they could do to prevent it from being severe? And there's really not a whole lot. At one point, we did have post-exposure prophylaxis, which was if you thought you were exposed, you could get a monoclonal antibody. That seems to have, really, it fell out of the approved uses, and part of it was a supply and demand issue. I think this is pretty unfortunate. I would really love to see it come back, especially if you know you were exposed to someone who had it, because this is something that actually could make a big difference. And it's something that we actually have data for, but unfortunately is not something that is available to us at the moment. So definitely going to be keeping an eye on that, because really that is the one thing that after you're exposed, but before you catch it, could actually make a difference. And it was available for a short time. And then around the time of Omicron, they removed that authorization. So I'd love to see that come back. So I'll just leave that there, because what I'm going to talk about next has, some circumstantial evidence, if you will. It is very interesting, but, this is not going to be the randomized double-blind control trials that we want to see. And if that's all you want to see, then this part may not be of interest to you, but I found it very interesting and thought it worth talking about, because these are things that are definitely low risk. And so could they possibly help? I'm going to try to walk through a little bit of what we know. And so first, I'm going to talk about the sort of nasal mucosa and what is going on when we first catch SARS-CoV-2. And so basically, the majority of cases are coming through into the nasal or oral mucosa. And we know that because we breathe it in. And remember, it is transmitted through droplets or aerosol, and we are inhaling it. And then from there is where we're getting sick. And this is why I've mentioned so many times that I really can't wait for there to be a good nasal vaccine, in the hopes that we'll get some what's called mucosal immunity. So we'll have some antibodies right there ready to go, kind of in the mucosa. Right now, the vaccines that we have do a really great job of keeping us from getting really sick, but because they are really giving us kind of the blood response, because it's going into our muscle and we're getting the antibodies in our blood, it's not doing the best job of preventing us from catching it. So wonderful, it's keeping us from going to the hospital and dying. That's what we wanted. Those were the desired endpoints of vaccine. That is still the case. but wouldn't it be nice if there was a way to stop it from getting in the first place? And so that's why I'm hopeful that one of these days we will get a nasal vaccine. We don't have that yet. But one of the things that researchers have noticed for a long time is that we have a lot of receptors in our nasal and oral mucosa, and even in the lungs, lining our lungs, that have ACE2 receptors. And remember that SARS-CoV-2 binds to the ACE receptor in order to actually get into our cells. And so that is the first place that the SARS-CoV-2 is going to go ahead and latch onto our cells and get in, and then from there go into the rest of our bodies. And so one of the things that that has been noted kind of in the lab and in basic science, kind of looking at SARS-CoV-2, is that one of the ways in which it actually latches to our receptors, our ACE2 receptors, is first it breaks itself kind of in half with a enzyme called furin, F-U-R-I-N, and that cuts the SARS-CoV-2 in half, and then that allows it to bind to our ACE2 receptors more easily. So why is this important? Well, there have been some studies that show that when you take saline, a saltwater solution, that actually interferes with furin, and it makes it so that the SARS-CoV-2 can't break itself into two parts and then enter the cells easily in order to replicate. And so that the hypothesis from that is that potentially hypertonic saline or salt water would be a feasible way to stop the virus from being activated, entering into our cells, and being able to replicate. And so I put a link to that in the post in case you are interested. One of the interesting things about it is that this was the case on several different of the mutations that we see with SARS-CoV-2. And we know that this feature of how SARS-CoV-2 acts is the case with the wild type as well as the mutations. And so it's not variant specific like our vaccines and like our some of our treatments are. And so that kind of makes it of interest. The study that I wanted to point out today is rapid initiation of nasal saline irrigation to reduce severity in high-risk COVID positive outpatients. And this was a study that was published just last month, August 25th, 2022, in the Ear, Nose, and Throat Journal. And what they showed is that flushing out your sinus cavity twice a day with a mild saline solution can significantly reduce your risk of hospitalization and death if you are a COVID patient. So again, they were looking at outpatients, and it's a small study, and they took 79 COVID positive patients who were 55 and up. So these were a little bit higher risk folks. And what they did was have those patients self-administer nasal irrigation using salt water mix. And they either had it mixed with iodine solution or with baking soda within 24 hours of testing positive. And they basically did matching, which I know we've talked about many times, where they tried to find a group of people with some similar demographics. And so they looked at a really large group that was actually reported in the same time frame by the CDC, and similar demographics, same time frame. Compare them to the small group of patients who did this self-administered nasal irrigation. And what they found is an 8.5-fold reduction in hospitalizations and no fatalities compared to the controls. So 8.5-fold reduction from just rinsing out your nose twice a day. So basically, to kind of break that down further, Out of the study participants, 1.3% needed to be hospitalized and none of them died. And then when you looked at that larger group of the matched controls, 11% either landed in the hospital or died. So again, it was an 8.57 time risk reduction. So this is very significant. And just to break it down further, that group from the CDC. So again, the group that did the nasal flushing or irrigation, 1.3% needed to be hospitalized and 0 died. And in the larger case controlled group, 9.5% were hospitalized and 1.5% died. So what the researcher said is that this reduction, if you take what it corresponds to, this would have corresponded to 1 million fewer older Americans needing to be admitted to the hospital. 1 million fewer older Americans would have needed to be admitted to the hospital. So this is not a perfect study. Like I mentioned, this is not a randomized controlled trial. That's actually not going to be easy to do because the intervention is actually, rinsing out your nasal cavity. Frankly, nobody's really motivated to do these kind of studies because what motivates people to do randomized double-blind controlled trial is if you have, a pharmaceutical or a treatment that you are selling. So that is just part of, capitalism as it relates to healthcare. It's not all a bad thing. We obviously have wonderful innovation that comes out of, competition and the profit motive. Let's face it, salt water, nobody's going to make any money off of it. So I'm not exactly expecting any great, elegant, randomized double-blind controlled trials anytime soon. If they come, that'll be great. I'll be looking out for them. Why? Because as I mentioned, this makes sense, theoretically, it makes sense from the biological points that I made about the furin and the salt water getting in the way of that. Also, there have been a lot of studies that are really old. I didn't want to bring them up here or cite them here, but I'll just mention that we've seen that by moistening the mucosal airways, by using saline solutions, there have been prior studies that show a reduction in the duration of colds and flus and other respiratory illnesses. So these things kind of all make sense. And even though the quality of the data that we have isn't where we would love for it to be, it's not where I would want it to be to really be able to make a hard recommendation. I think I'll say a couple things. One, that's easy. It's cheap. It's probably not going to hurt. I'll give a couple caveats. You should use boiled water or distilled water just in case where you are happens to not have clean water, or you don't want to obviously introduce anything. So boiled or distilled water, please. Be careful. Don't be aggressive. Don't stress yourself out. Don't hurt yourself. None of those would be helpful to the overall cause of wanting to, be in a healing mode and in a healthy mode. Some people use like a neti pot, like that little pot that you just pour it into one side, one nostril, and it kind of comes out the other. Some people find this incredibly uncomfortable. Some people do this every single day, like brushing your teeth. So it's just something to consider. And the things we don't know. So if you, let's say you like breathed in some SARS-CoV-2 and then you came home and then you rinsed it out, does that reduce your chances of actually catching it? Maybe, we don't know. We've seen that it can reduce the number of copies of the virus in the nose. So there is another study linked in the post that shows this. Again, small sample size, but they were able to show that by doing this rinsing, they could reduce the amount of virus in the nose. So could that mean that it then wouldn't be enough to progress into the lungs and cause a worse situation? Maybe, we don't know. If you do catch it and you test positive and you start doing this nasal irrigation after that, Could you reduce the duration? Could you reduce the severity? It looks that way. So if you want to take some boiled or distilled water, obviously do not use it when it's hot. But if you've previously boiled it or you have distilled water, and you are going to mix a half a teaspoon of salt, half a teaspoon of baking soda into 1 cup of that distilled or boiled water, and then flush out the nasal cavity with some kind of neti pot or sinus rinse bottle. The study that I cited was about doing it twice a day. Should it be twice a day? Should it be 3 times a day? Again, we don't have enough real data to know what the exact recommendation should be, but very unlikely to be harmful, may be helpful. And the only other precaution I would give is that I'm really talking about adults now. When it comes to children or babies, I really would want to see some better quality evidence before I start recommending anything like this. But I think this is a very low risk thing that does have some evidence behind it that it might actually help. So something to think about. And the second thing is about oral health. I did a pretty comprehensive overview in a prior briefing, and I have put a link to that briefing in the post in case you are interested. But the bottom line of this one is very similar in the sense that there's a lot of evidence pointing to the fact that if you have poor oral health, particularly gum disease, periodontitis, you have a significantly higher risk of ICU admission, the need to be placed onto a ventilator, and of dying from SARS-CoV-2. And they even were able to show, in the case of gum disease, increased blood levels of some of those indicators that we know are linked to worse disease outcomes with SARS-CoV-2. And so there's a study that I've linked in the post. And again, I went into a lot of detail on this on the prior briefing, but basically that folks with more severe gum disease had almost 7.5 times a higher rate of needing assisted ventilation, and about 37 times the odds of being admitted to the hospital, and about 15 times the odds of dying. So this was very staggering in terms of the data that they were able to find. And this was one of those situations where we don't know if it's a correlation. So because you have poor gum health, is that also because you just have poor other type of health, physical health and things like that? But they did do their best to kind of do some case matching here as well. But I think that, it's a very similar kind of premise in that you've got a lot of ACE2 receptors in the oral mucosa as well. And the mouth, actually, we know, can be a reservoir for viruses and bacteria. And so if you don't have a good barrier there in your mouth and in your gums, as would occur with gum disease, then this could lead to SARS-CoV-2 kind of staying in there as a reservoir and then replicating, and then actually getting into the lungs, into the systemic circulation from the saliva. So we still got a lot to learn. And, once again, there's nobody rushing to do these studies. Although there are some mouthwashes in this case that have been recommended. I put the link to the post of a hospital protocol from the UK that does include some specific oral hygiene recommendations that is based on this research that the mouth is a reservoir and a site of viral replication, and that the virus could pass from the saliva to the blood, to the lungs, and so on, so that it's not just through inhalation. So this is other good food for thought. So we're going to want to brush carefully at least twice a day, especially before bedtime. Take a look at the UK hospital protocol. You may want to purchase some of the mouthwashes that they recommend. They are specific types. Also flossing, also making it to the dentist. So again, very little downside. I actually have no downside to report or any precautions around good dental health. good dental hygiene, other than to say, make sure your dentist is practicing good COVID safety protocols. And there are a number of them in the Bay Area, I'm very happy to say, who understand the risk associated with SARS-CoV-2 for themselves and their staff and their patients alike. But give them a call, find out, are they using N95s as they absolutely should be? Do they have good ventilation? Are they crowding folks in reception, or they have a way you can wait outside and come in, and so on? There are a number of mitigations that can happen in the dentist office. And I bring it up very specifically because that is the one place where you have to take off your mask in order to get the service. So you want to be sure that you're in good hands and that folks are taking that piece seriously. And so I'm going to end off with a reminder about Novavax. I hope that you can help us get the word out about this vaccine. Remember, this is a non-mRNA COVID vaccine. So for some people, this may be important and compelling, and we're finding that people just really don't know about it. We have it available at Roots. We vaccinate every Thursday and Friday from 1 p.m. to 4 p.m. And you can also check the locator, which the link is in the post, so that you can find it somewhere near you. We're just finding that there's not a lot of outreach, not a lot of education happening. So we want to make sure that you know some of the talking points about Novavax in case anyone that is in your circle or that you care about remains unvaccinated. This may make the difference. So remember that the Novavax COVID-19 vaccine is a protein subunit vaccine. It's non-mRNA. It's a protein subunit vaccine. It contains pieces of the virus and an ingredient that is called an adjuvant, and that helps your immune system basically recognize if you get presented with SARS-CoV-2 again, your immune system will protect you against COVID. This vaccine type has been used for decades. It uses the same technology as some of our flu vaccines, our hepatitis B vaccines, our shingles vaccines. So we're very well versed in this vaccine technology. And just like all the COVID vaccines, the vaccine gives you protection without the risk of the serious consequences, death, hospitalization, and long COVID. And this vaccine is currently 2 doses, 3 to 8 weeks apart for individuals 12 years old and up. And for most people, it's going to be 8 weeks apart. That's going to give you a better immune response. And will this become a 3-dose series later? Well, I would not be surprised if it did, but we'll wait and see, because remember that with the other vaccines, they were given a lot more close together, 3 weeks, 4 weeks apart for the Pfizer and Moderna respectively. And then later we found out, oh, we need another one after so many months. So by spreading the first 2 doses out 2 months apart, it is possible that we will get a longer duration of protection, but will we eventually need to add a 3rd dose later? That is completely possible. In fact, right now, the recommendation is that at least another 8 weeks after that 2nd dose, that you get a booster. And right now they're saying that you should get the Pfizer or Moderna booster. But let's not worry about that right now. If you're completely unvaccinated, let's go on and get the Novavax. 8 weeks later, get the Novavax. And I would not be surprised if by then the Novavax was approved for a booster dose as well. And then for those folks who, for whatever reason, would prefer Novavax as a booster, hopefully it will be approved for that soon. Unfortunately, currently, right now, that's just not the case. So right now, for the boosters, we're going to need to go with either Pfizer or Moderna. It is recommended at this point for everyone 12 and up to get an updated booster if it's been at least 2 months since your primary series or your last booster, or even a COVID infection. And so we're going to remember that we still need to reduce transmission. We still need to reduce deaths. So what are we going to do? We are going to gather outdoors as much as possible instead of indoors. If you do need to go indoors, and particularly in public settings or with people who are outside of your bubble, then wear a well-fitted filtration mask. Your mask is going to have to stand on its own, because unfortunately, in so many places, Folks just are not wearing masks, or they're wearing ones that don't provide filtration. So you're relying on your mask and your mask alone. And so you're going to want it to be well fitting, and you're going to want it to be a N95. And if not, then a KN95 or a KF94. And also limit your time indoors. Don't linger too long. And if you're going to be gathering indoors with a smaller group or things like that, let's not forget about testing. Testing on the way in is another important layer. It's not perfect, but it is an important layer of protection. And you're going to want to improve indoor ventilation by opening windows, HEPA filtration units, running the HVAC, and so on. And then to prevent death, because I don't want to see any more COVID deaths, and I don't think we need to. We could be eliminating the vast majority of deaths that we're seeing now. And remember, it's over 400 people per day. And here in Alameda County, we've been losing about a person per day for some time now. And so that is just too much. And the way we can do that is, of course, vaccination. But if you're exposed, if you get symptoms, get tested. And I would suggest that if you are in a group of people who would be eligible for treatment, so let's say the Paxlovid treatment or some other treatment because you're higher risk, then I would say you should actually get tested with the PCR test. Doing the home test, we've been seeing people testing negative for 3 and 4 days while the PCR is positive. And so that just means being able to get in there and start treatment sooner. As a reminder, our treatments are kind of in this order. Our top line, first line treatment is Paxlovid. It's the pills that you take for 5 days. It's approved for 12 and up. So we don't want to see any more children going to the hospital with COVID or even dying of COVID. COVID is the 3rd or 4th leading cause of death, depending on which age groups you look at, even for children. This is not acceptable. We need to vaccinate children. We do not want any more vaccine preventable deaths. But in the event that they are high risk, or which includes being unvaccinated, then 12 and up is eligible for Paxlovid, and remdesivir, which is our second line treatment, actually is approved down to the newborn period. So if we have children who are at risk, and we still have children going to the hospital and at even higher rates than some of our older adult age groups at this time. Why? Because they're not vaccinated. And so if we find ourselves in this situation, then let's keep in mind that we do have options with treatment. So let's just not forget that. And our 3rd line treatment is still the monoclonal antibody, bebtelovimab, and kind of, last in place there is molnupiravir, which is only in sort of limited situations that this is really a treatment of choice. We've got 3 other great choices ahead of that one. And so all of this means that if you don't have a primary care provider, you're going to need to get one, because it is going to get harder and harder to come by treatments, vaccines, and so on as this pandemic becomes commercialized, as the COVID response becomes commercialized, and as some of the emergency components and the emergency funding goes away. So you will need to be relying on your healthcare coverage or your primary care provider. If you don't have one, please get one. We're going to want to vaccinate and boost. For those loved ones who are still not vaccinated, please talk to them about Novavax. Let them know there's a non-mRNA option available to them. If immunocompromised or for some reason unable to be vaccinated, Evusheld is still a great choice. We're going to have to keep an eye on how it does against some of these newer variants that are coming on the scene. But for now, it is active and protective for over 80% of what's circulating at this time, and it gives 6 months of protection. So very, very important for immune compromised folks on steroids, on immune suppressive medications, on chemotherapy, etc. And we're going to want a treatment plan. So you're going to talk to your doctor ahead of time to figure out now, are you someone who would get treatment, and what are the instructions if and when that was to happen. And of course, as usual, we're going to maintain a balanced diet, get some exercise, manage your stress levels, consider a multivitamin supplement with additional vitamin D, and get a good night's sleep. Please submit any of your questions or any feedback you might have in the comments by direct message or by email to admin@rootsclinic.org. Thank you so much for joining us. Look forward to seeing you again next Tuesday at 10 a.m. See you then.